Well, welcome everyone to another Hospice and Palliative Medicine conference. We're going to be talking today about care of the dying patient, which is a very important topic, especially since we only have one chance to get it right. I have no disclosures. So we're going to talk about the physiologic signs and prognostic tools near end of life, as well as how to best support families and address some of their common concerns, and identify and rapidly treat symptoms for comfort care. And we're also going to touch on normal versus abnormal grieving. And there will be a specific, actually a few lectures on hospice specifically. So I'm not going to go into detail on hospice today. So dying in America is something that's been looked at for many years. And over the years, they have identified there's a pressing need to improve end-of-life care because of barriers in access to palliative care, a mismatch between the services that are needed versus those that are obtainable, inadequate numbers of palliative care trained physicians, and inadequate knowledge among general practitioners, as well as a fragmented care delivery system. If you ask most people, they would prefer to die at home versus the medicalized death in the ICU hooked up to all kinds of tubes and things. Thankfully, the trends over the years have shown that more and more people are getting to die at home and less in the hospital. And I think that's largely because of the advent of palliative care and the goals of care discussions that have identified people's wishes before they were actually actively dying and too unstable to transfer. So the goal is to help you have some of these tools so you can identify when someone is nearing the finish line, maybe within the next few days or weeks, perhaps even month or two, and try to talk with them about their end-of-life wishes. There was one case that I saw a number of years ago, an 88-year-old woman who presented to the emergency department with severe shortness of breath, weakness, nausea, anxiety for a week. Her energy and appetite were going down. She was sleeping more, getting weaker, and she developed some chest discomfort and palpitations and was hypotensive and hypoxic. And eventually she became obtunded to the point where she really wasn't swallowing very well. She was having a lot of secretions. Her exam was consistent with congestive heart failure. She also had peripheral cyanosis, mottling, and prolonged capillary refill. EKG did show evidence of a perhaps recent MI, and the chest X-ray showed cardiomegaly, and the lab showed an elevated troponin. Initially, she fought the non-rebreather mask, didn't tolerate BiPAP, and did receive IV fluids because of hypotension, but of course this made her respiratory status worse. And basically she was in acute respiratory failure and cardiogenic shock due to a recent MI and probably a second MI that was ongoing. Medical treatments were failing. The emergency department called us to address goals and to provide symptom relief. So this is a case where we kind of got involved at the very last minute because the patient was clearly actively dying. So we're going to talk about how we can recognize when someone is actively dying, and then focusing on some of the person-centered goals. So what's most important to the patient and the family? Do they want curative treatment in the ICU with a ventilator, life support, and inotropes and balloon pump and all these other invasive procedures, or do they just want comfort? A lot of this boils down to what the patient wants at end of life and where they would want to pass away when they get to that point. Also addressing what are the things that are important to the patient and family at end of life, any tasks or any concerns that they have. And then what's involved in comfort care? How can we get her symptoms controlled rapidly? So as a physician, there are several tasks at end of life that really fall on your shoulders. One is prognostication. Yes, it is our job to make an educated guess and to communicate that, like any bad news discussion, with patients and families so that they can plan appropriately. We also want to communicate this information honestly but compassionately and provide anticipatory guidance, what to expect and how to prepare for what's to come. Also discussing realistic treatment options and the risks, benefits, and alternatives, especially if they're at a crossroads. Well, do we go to the ICU? Do we go on the ventilator? Or do we just go comfort care? Or is it something in between? How do you help them cope? Providing not just information, but also emotional support and empathy. And then anticipate and treat distressing symptoms. And then, of course, pronounce death and sign the death certificate. Studies over the years have looked at what patients want at end of life, and all of them want compassionate honesty. They don't want the truth to be sugar-coated or bright-sided. They want to know if they're dying. Many times I've heard patients or families say, doc, am I dying? Or is mom or dad going to die soon? And they want to know because it affects their decisions that they make. People also want to be in control and have some dignity in the life. And of course, they all want to avoid suffering as well. They want to be comfortable. They don't want to have a prolonged dying process, especially if whatever they have is not immediately reversible. They don't want to be a burden on family, and they want to be able to enjoy meaningful activities. So specifically, in terms of support needs, they can be broken up into 4 different areas. Physical, which has to do with the symptoms and comfort medications. Psychosocial and emotional, by allowing family to be there, providing empathetic support, and recognizing anticipatory grief. Spiritual, which involves addressing fears of dying. And our chaplains are great at helping to listen to patients as they tell their life story, or the family as they tell the life story, review, help them find peace and closure at end of life, and also help them prepare for and cope with bereavement. And then, of course, hospice, educating them about this option, about determining the location of services. Is family available to provide care at home, or would they need a referral to a facility? Which agency do they prefer, and are they even stable enough to move out of the hospital? Or could they even be a candidate for generalized inpatient hospice care? Again, that'll be covered in the hospice lecture. But it is something that needs to be thought of as people approach end of life. So Doc, how much time is left? That's the million-dollar question. We don't always have a clear-cut answer, but we can look at the pattern and rate of decline and use some prognostic tools and look at some physiologic signs. There is a lecture in the future on prognosis specifically, so I'm not going to spend a lot of time on this, but I did want to give you some basic tools that are really easy to use and very helpful in terms of recognizing when someone might be in that home stretch of the next couple of weeks. So there are several factors associated with poor prognosis. If it's a severe acute illness, and if they have rapidly declining function, nutrition, and cognition, that's a wake-up call, a sign that time might be getting short. If they have underlying poor reserve due to advanced or end-stage disease, advanced age, debility, frailty, and then, of course, high risk of sudden decline due to vascular events, bleeding, infection, obstruction, or aspiration. And there are many different disease trajectories, but if there's a sudden catastrophic decline, then that can mean a much shorter course. Initially, there might be stability and then rapid decline, such as with cancer. So the sudden decline would be here, the more rapid decline as cancer gets toward the end. Fluctuating downhill course with organ failures like heart failure and COPD, any one of which could result in their death, but overall the trend is downward. And then slow gradual decline, such as frailty or dementia. And these 2 tools, the Palliative Performance Scale and Palliative Prognostic Index, can be helpful in helping people plan for the next month. So the Palliative Performance Scale, I'm really going to focus on the lower half of this, which is the 10 to 50%. This is a modification of the Karnofsky performance status, and it looks at their ability to walk on their own, do any work, provide self-care, oral intake, and level of consciousness. And someone who's at 50% is somebody who's mainly sitting down or lying down. They really can't do much work. They need a lot of assistance, and their oral intake may be normal or reduced. When they get down here to 30%, that's when they're totally bedbound. They cannot get out of bed on their own. They require a lot of care, and they can't do any work, have reduced oral intake. 20%, this is where we're down to SIPS and full drowsy or confusion, and then 10% is where they're basically only able to do mouth care, and they're drowsy, lethargic, or comatose. And the reason this is a very helpful tool is that it helps prognosticate when someone is in the weeks to months category. 90% of patients with a score of 50% or less due to medical illness die within 6 months. And the 6 months is handy because that helps qualify people for hospice. 3 factors predict survival less than 4 weeks: weight loss, cognitive failure, and dysphagia to solids or liquids. Another helpful tool is the palliative prognostic index, which takes into account the performance scale and also oral intake, edema, which is really a marker or measure of hypoalbuminemia due to medical illness or malnutrition, dyspnea, rest, and delirium. And a score of more than 6 predicts survival less than 3 weeks, with about 80 to 85% sensitivity and specificity. So again, this could be a wake-up call for people when we're starting to see these things, and it's time to start talking about what matters most for whatever time they have. So how can we recognize when someone is crossing the bridge, when they're beginning the dying process? And I say process because it's not like on TV where somebody is fine and awake and conscious, and then all of a sudden they're gone. That's rarely how it happens. Usually there's a little more warning. So let's go over some of the warning signs. So some of the early signs when someone is at the days to weeks category, it's important to note that how quickly they're declining is predictive of how soon they might die. So if someone is declining month by month, you're probably looking at months to a year. If they're declining week by week, you're probably looking at weeks to months. If they're declining daily, then you're probably looking at days to a few weeks. And so things that we often see are progressive fatigue, weakness, anorexia, declining function. They're becoming more lethargic or sleepy. They're sleeping more, eating less, doing less, just kind of winding down. When someone is at the late stage or hours to days, this is when we begin to see vital sign instability, such as pulse variations, blood pressure, presence of fever. They become more sleepy, more difficult to awake, and may even go into a coma. They may be tachycardic or bradycardic or alternating in between. If someone is tachycardic for days and then all of a sudden they're normal and then bradycardic, watch out, it's going to be soon. Also, we can see decreased perfusion, which in the skin, that would manifest as cool skin, peripheral mottling, and cyanosis. From a respiratory standpoint, the breaths become more shallow. They become more irregular, fast, and slow, apneic periods. The development of bronchi, often from pooled secretions because they lose their gag reflex and have trouble swallowing. And they also begin to have oliguria or anuria, incontinence. Here's some dramatic examples of peripheral mottling. Shane Stokes' respiration pattern, fast, then apnea for several seconds, and then fast again, and then the secretions. So almost universally, families will say, I don't want my loved one to suffer. And so what does it look like when we're talking about suffering? Well, families often perceive that not eating is suffering because they feel like their loved one is starving to death. It's helpful to educate them that the lack of appetite is actually a natural part of the disease progression and also associated with the dying process. So technically, they're not starving to death because they're not, their body doesn't need or want calories at end of life. It shifts into a catabolic state. Loss of appetite is normal. Food is not appealing. And if you try to force it, people get nauseated, bloated. They just don't feel well. They might even aspirate it. And artificial nutrition is not even used by the body at end of life. It's a metabolic burden that the body can't handle as it is in a catabolic state. And so it actually does not prolong survival when people are within a few weeks of end of life. And people can live comfortably on minimal food for up to 30 days and minimal water or no water for up to 14 days. So it's important to cater to individual preferences. artificial nutrition may actually worsen their symptoms, secretions, nausea, dyspnea, bloating. So don't make food a battle. Find alternative ways to show love and care besides food, even though food is associated in many cultures with love and affection. So let the patient's stomach be your guide. If they want something, they might only want a taste or a sip or a bite, and then they're satisfied. So that's okay. All right, so now let's get into some of the nitty-gritty about comfort care. We just want him or her to be comfortable. What does that look like? So in terms of nursing care, it usually means limiting vital signs to once a shift, but a non-invasive vital sign would be the respiratory rate. You can count that without disturbing the patient. And I recommend checking that every 4 hours to assess comfort. Why? Well, if someone is in pain, if they're anxious, or if they're short of breath, their respiratory rate is going to be high. Generally, if it's above 20, then it's possible there could be symptoms there. Now, that could also be from metabolic causes too. But anyway, it's a non-invasive barometer, if you will, of their comfort. Mouth care every 2 to 4 hours if they're no longer eating or drinking. Lip balm to keep the lips moist. Eye drops or eye ointment like Lacrolube if they are kind of keeping their eyes half open and not shutting them. Skin care, turning them every 2 to 4 hours is tolerated, and using an air overlay mattress to try to prevent pressure sores because they're going to be too sleepy or too weak to turn themselves. And then a Foley catheter to relieve incontinence or prevent bladder distension. And then discontinue non-comfort measures. A lot of things in the hospital, we don't think about it. They just become automatic. Oh yeah, daily labs, all these medications, the patients end up with a cup full of pills that they have to take every morning. So looking at things that aren't really necessary anymore for the patient's comfort, multivitamins, statins, perhaps even things like Synthroid, some of the blood pressure medicines, if their blood pressure is dropping, or if they're at the point where they're no longer able to eat and can't take any pills or swallow any pills, then get rid of the pills. Even you have to be careful with some medicines like insulin, because as they're not eating, then their blood sugars are going to drop. So insulin might become optional depending on their status. Even monitoring, heart monitors, even checking routine labs. If they're not eating and their blood sugar isn't at risk of going dangerously low, then you wouldn't even have to check blood sugars at this point if they're actively dying. And then withdrawing artificial life supports, deactivating ICDs, and then adding medications to prevent or treat symptoms. Common symptoms: pain, shortness of breath, and anxiety or restlessness are probably the top three, or certainly the most distressing in part of families. But then also things like secretions, fever, anorexia, nausea, itching, fatigue, lethargy may be experienced. So what about opioids? Is this something that's good, bad? There's some misconceptions about opioids. Oh, they're going to kill you with morphine. It's liquid death. I actually had a family say that to me once. Isn't morphine just liquid death? It's like, no. So when somebody has shortness of breath or pain, opioids are absolutely indicated to help treat them. And the main thing is basing the dose based on the intensity or the severity of the symptoms. And the opioid should be titrated for relief of dyspnea and reassessed to see what dose is working and how much is the right dose. And the goal is palliating symptoms without hastening death, and communicating also about palliative and end-of-life care. So according to the ACCP consensus statement, they absolutely say if someone has advanced heart or lung disease, use opioids. So their first line for moderate to severe pain or dyspnea, they can be given IV, sublingually, orally, sub-Q. They can even be given rectally if somebody has no other way to get it. In a crisis, you can bolus the IV doses every 15 to 30 minutes, escalating until comfortable, and then arriving at some maintenance dosing. Opioid naive, you could consider 1 or 2 milligrams of morphine for starters, but then going up if needed. Fentanyl, and these are all equivalent doses, 1 to 2 milligrams of morphine, fentanyl 25 to 50 micrograms, or hydromorphone 0.25 to 0.5 milligrams IV. These are all equivalent doses to each other. If someone's opioid tolerant, you could dose higher doses and increase the doses as needed. There's really no ceiling dose except that which causes excessive sedation or respiratory depression. If there's enough time, if somebody's going to be alive long enough to benefit from something like methadone, that's an option as well. One thing about methadone is it's available as an elixir, 10 milligrams per ml. So if somebody really needs it because of the neuropathic pain component, and they need something long acting, and they've got probably at least a week to a month time frame, then methadone could be an option to use. And they do have the Intensol sublingual solution if somebody can't swallow pills. Also ketamine for neuropathic pain that's refractory to opioids. Dextromethorphan can also work, but again, that's going to be more of a longer term issue. And then using an IV infusion or PCA pump if the pain is severe, if it's ongoing, if they're needing frequent doses, like every 2 to 4 hours, it's a very useful bridge. It can either be a bridge for comfort care, a bridge until they pass away, or if they're not yet at end of life, then it can be a bridge to help them get comfortable and then transition to a long-acting opioid. It provides uniform pain control. It's safer and better tolerated because there's less hypotension and sedation. And remember, boluses achieve pain control and IV drips maintain pain control. So you're not going to get someone under control just by starting a drip or titrating up the drip, because that's going to take hours as opposed to minutes with the bolus. We had a lecture on this about 2 weeks ago, but I'll just review. So opioid infusions, morphine, fentanyl, hydromorphone are the common drugs. Avoid morphine in renal failure. Fentanyl is preferred. Consider how much they've needed over the last several hours. Divide the dose by the number of hours, and you get a starting rate. And then you can bolus every 15 to 30 minutes, and then change the infusion rate every 6 to 8 hours, which is because it takes that long to reach steady state. And so you're going to want to use boluses in the meantime. Okay, so what about near end of life and opioids? So we actually do need to reduce doses because the organ failures like liver dysfunction or renal failure prolong the clearance of the medications. And then if someone is not eating much and they're losing weight and they're becoming cachectic, they're not really going to absorb transdermally or fentanyl patch, for example. So use mainly oral or sublingual or IV. If they have a fever, there's more circulation to the skin, so you can reduce the fentanyl patch dose. For dysphagia, you can use IV medications instead of orally, or sub-Q, sublingual, transdermal, or rectal routes. And then, as mentioned, the renal or hepatic failure, we would use lower doses, less frequently, and mainly PRN, and try to avoid long-acting forms of the medications because the metabolites are going to build up. Also avoid codeine and tramadol if there's renal failure. Fentanyl is preferred in renal failure, followed by buprenorphine, methadone, hydrocodone, hydromorphone. So what about in dying patients? Do opioids hasten death? And I'm pretty sure they're going to put a question on this on the boards. They always have a question on double effect on the boards. But the real answer is that no, opioids don't hasten death because they make people more comfortable. And when people are more comfortable, their bodies are less stressed, their heart is less stressed. They actually relax. They just tend to do better. Their color improves. Now, this would be assuming that you're using proportionate doses and not a dose way out of proportion to what the patient needs. So double effect is where you have a benign intention. You want to relieve pain and suffering. So you give the opioid, but the adverse effect is that the patient either stops breathing or goes unconscious or something like that. Your intention with giving the opioid wasn't to end the patient's life or to kill the patient. That would be considered euthanasia as opposed to just practicing good medicine. And so death after opioid administration technically is due to the underlying disease rather than due to the medication, again, provided it's a proportional dose. So we do have an ethical duty to provide comfort and relief, especially at end of life. Now, anxiety is another common symptom at end of life, and there's actually a vicious cycle between shortness of breath and anxiety. The more short of breath you are, the more anxious you become. The more anxious you feel, the more you feel like you can't breathe and you start to panic. So what are some strategies that we can use? So first of all, identifying the triggers. You know, if the anxiety is due to shortness of breath, well, then treat the shortness of breath. Bring a fan in the room. Give them low dose opioids or escalate the doses of opioids if needed. Try to provide a relaxing environment, either family or music or psychosocial and spiritual supports, companionship. Some hospitals have either a No One Dies Alone program or compassionate companions or something like that, where people can sit with people as they're approaching end of life and help them be calm and comfortable. Anxiolytics are also useful if opioids are insufficient or if it's a primary anxiety issue. So lorazepam, midazolam can be used. Lately, there's been a shortage of IV lorazepam, so we've been using low doses of midazolam. And then if someone does have a longer prognosis and they need something long-acting, you can use clonazepam. I've actually seen higher doses, like up to even sometimes 1 or 2 milligrams in people who've been on benzos for years. Terminal restlessness is another symptom that kind of freaks patients' families out because they think, whoa, this is weird. You know, mom's talking to her deceased mother. This is weird, you know, or she's waving at dad who died 2 years ago. But generally, it's not distressing for the patient. It's causes the family some concern, but it's not something that's something that you necessarily need to treat with antipsychotics, for example. It can be a sign of the dying process that someone's getting closer, where they see or hear or talk to deceased relatives. Obviously, you know, in your differential diagnosis would include, you know, is there untreated pain? Are there side effects of drugs like benzodiazepines or opioids or withdrawal? Is there kidney or liver failure, electrolyte imbalances like low sodium that can make people act differently than normal or become delirious? Is there fecal impaction or urinary retention? Or are there any psychosocial or spiritual factors that need to be addressed? So delirium with agitation, again, there's a whole other lecture on this this fall, so I'm not going to spend a lot of time, but basically, if someone is agitated and delirious, generally at end of life, families just want to get them calm and comfortable. Obviously, if there is a treatable cause that might turn things around, then that's certainly appropriate. But if the family just wants them calm and comfortable, frankly, antipsychotics are generally helpful. There is an FDA black box warning in the elderly of increased mortality, also the risk of QTC prolongation. But generally at end of life, the symptom benefits usually outweigh the risks, and families just want them calm and comfortable. So you can use Haldol, IV, PO, sub-Q, every 1 hour if needed, but again, and you can even go up to 5 milligrams if you need to. Olanzapine can be given orally or oral dissolving tablet, quetiapine, chlorpromazine. And then if they can swallow pills, trazodone at bedtime, if it's more mild and they just need something to help them sleep and relax, that's an option. Also, if they have Parkinsonism, quetiapine is the less likely to cause extrapyramidal side effects. But again, these are not, antipsychotics are used after other measures are exhausted, like behavioral or environmental, or reassurance, treating the underlying cause. And I think for board purposes, in general, they try to steer you away from antipsychotics just because there have been studies that have shown some mixed reviews with delirium. But if it's a situation where the patient is wild and the family says, we just got to calm them down before they hurt themselves or hurt someone else, then you do what you have to do to get them comfortable. Secretions. This can also be very distressing to families. Patients are usually unaware because they're usually asleep. For board purposes, they tend to recommend repositioning, postural drainage. They also recommend education and reassurance of the family before turning to medications. Suctioning, I found it generally is more traumatic. It doesn't necessarily help unless there's something obviously in their mouth or the back of their throat. Anticholinergics are only used if there's severe symptoms or if there's family distress despite education and reassurance. So we have some options. Glycopyrrolate or Robenil can be given orally, can be given IV. It does not cross the blood-brain barrier, so it's less sedating. Scopolamine patch, if they can't swallow anything and need something longer acting than glycopyrrolate, or if they're needing multiple doses of glycopyrrolate, then you can add a scopolamine patch. Hyoscyamine or Levsin is another option that can be given sublingually. And atropine solution. It's the atropine ophthalmic solution, 1%, but you give it sublingually every 30 minutes as needed. Tends to work pretty fast because of the anticholinergic effects, but it also causes tachycardia. So if they're already tachycardic, you probably would want to avoid that. Fever, often due to atelectasis or even infections. Physical measures can be used like cool, damp cloths, cold packs in the axillae, fans, and also antipyretics. So acetaminophen, which can be given rectally, NSAIDs, or dexamethasone if it's severe. Nausea and vomiting. There's a lot of things that can cause this. And I think there's a whole lecture on nausea and vomiting later in the year. But medications, uremia, bowel obstruction, ascites, gastroparesis, gastritis, dehydration, increased intracranial pressure. Reduce any unnecessary meds, focus on the oral preferences. And then antiemetics, either IV, rectal, oral. So ondansetron is very commonly used. Prochlorperazine can be given rectally. Metoclopramide, if they don't have prolonged QT, can be given, especially if you suspect gastroparesis. And then second-line medications, dexamethasone, Haldol, very potent antiemetics. But obviously, because of the side effect profile, we would use them second line. And then in the situation of a malignant bowel obstruction, besides NG drainage and IV fluids and proton pump inhibitors, you could give Decadron and octreotide. The Decadron helps reduce bowel wall edema. The octreotide reduces intraluminal secretions. And so it's a good non-surgical way to treat a malignant bowel obstruction where the surgeons feel it's too high risk to operate, or maybe the patient doesn't want an operation. We have a patient who just saw yesterday who refuses an NG tube. She's got a malignant bowel obstruction. So we're considering putting her on this if there's no evidence of infection. Itching, often seen in renal failure because of the uremia. It can be exacerbated by morphine, and that's because of the direct histamine release, which is not an immune or IgE mediated thing. So it's not technically an allergy, but if patients get itchy when they take morphine, they're not going to want to take morphine. So you'll want to use a different opioid. You can also use cool washcloths on the skin, use skin moisturizers, lachydrin, for example, antihistamines like diphenhydramine or hydroxyzine, and gabapentin can also be helpful. Also at end of life, the issue about withdrawal or refusal of artificial life supports. Of note is that it's been established years ago that it is ethically, morally, and legally permissible to withdraw or refuse artificial life supports, whether that's nutrition, whether it's ventilators or other forms of life support, dialysis, vasopressors, high flow oxygen. And basically, when the burdens outweigh the benefits per the patient or the surrogate decision maker, and this allows natural death from the underlying diseases rather than prolonging life artificially by machines. And that's probably the best way to phrase it when patients or families say, well, isn't that suicide or isn't that euthanasia? we can't do that. We can't kill grandma. No, you're just removing the burdensome machines to allow natural death from the underlying illness. So we touched on some examples, of course, mechanical ventilation, BiPAP, high flow vasopressors, dialysis, cardiac devices like a balloon pump. And generally, if somebody has a pacemaker, we don't need to deactivate it. Doing so will usually put them in immediate acute congestive heart failure from third-degree heart block. Not a good idea if you want to keep them comfortable. However, if they've had a devastating brain injury and that's literally the only thing that's keeping them alive, then you can deactivate it. But the device representative will make you push the button to deactivate it. I've only had to do that, I think, once or twice in my career. But I think that, I think just because of their concerns, they make the physician do that. LVADs are not typically withdrawn. However, if they are, then it, again, you'd be facing a situation where there could be immediate symptoms that need a lot of medication. So it's best done in a very, like in a hospital situation. So once the artificial life supports like ventilators or dialysis are removed, the prognosis can be variable, and it depends how critical their condition is beforehand and what life supports are being withdrawn. So generally, most people die within a few hours. It could range as short as minutes or as long as a few days. Every once in a while, someone will actually survive, and they end up living a lot longer than expected. For dialysis, the average is about a week, but the range is about 1 to 14 days. But if they're making some urine, it could be longer. I've seen people go a few months afterwards. Typically, as they become more uremic, they become more lethargic and then lapse into a coma and then eventually pass away. So ventilator withdrawal is a special process that we can do when someone is no longer, or when their family no longer wants the artificial life supports. Obviously, document your discussion with them about their goals of comfort, their desire for removing the artificial machines to allow natural death from the underlying illness. Staff is required to notify gift of life. It doesn't mean they're automatically going to be an organ donor, but gift of life then can approach the family if they want to donate or not. Also providing guidance about what to expect, about the fact that comfort medications would be given beforehand as well as afterwards to make sure they stay comfortable, not only to prevent distressing symptoms, but obviously to treat symptoms as well. And specifically for air hunger, using opioids, for anxiety, using benzodiazepines, and for secretions, using glycopyrrolate. Giving these doses at least 15 minutes before withdrawal is usually recommended, because then it can be taking effect and preventing the distressing secretions, the anxiety, the shortness of breath. And people don't always need a lot, or maybe they don't even need both opioids and benzos. Maybe they just need the opioids. But certainly having the others on hand is helpful. And then once the medications have been given and you're sure that the patient's comfortable, usually we have the family step out for a few minutes, because it's kind of gross to hear the suctioning of the secretions. And so then the tube is removed, the cuff is deflated, ET tube is removed. Oxygen is usually discontinued at the same time. Suctioning is done, the mouth is wiped up, patient's cleaned up, family comes back in. And then you can give bolus doses of medications as needed, depending on how things go. Titrating the opioids, use a drip if the prognosis is hours to days, not if it's minutes, because by the time the drip kicks in, the patient will have already passed away. Specific doses are less important than symptom relief. In other words, you do whatever it takes. You start low, you increase as needed, and find the dose that's going to work for that patient. It's very individualized. And generally, you want to get the heart or the respiratory rate down below 20 to 24, and no evidence of grimacing or agitation or restlessness. I'd like to shift gears now and spend a few minutes talking about grief and bereavement, because this is also covered on the boards, and it's an important thing to know about, especially as you're dealing with patients and families as they may have concerns or emotional needs at end of life. So it's interesting, the history of all this. So initially, early part of the of the 20th century, Sigmund Freud said that grieving is a natural process that should not be tampered with. In 1969, Elizabeth Kubler-Ross wrote a book on death and dying, which outlined the 5 stages of grief, and I'll touch on that in a minute. Then they came up with a 2-track model of grief, which was more of a deeper, or 2-track model of bereavement, providing more insight. And then by the 1990s, they were questioning the simplicity of grief, realizing it was a lot more complicated than that. So by 2007, they established the diagnosis of complicated grief. And then prolonged grief disorder was added to the psychiatric handbook in 2022. So 5 stages of grief and dying, and this is important because when you're giving bad news to somebody, oftentimes they're going to react initially in a way that shows that they're in denial or they're angry. And so recognizing not only with delivering bad news or news of a serious prognosis, but also when people are faced with the fact that they or their loved one might be dying soon, they're going to go through these same 5 stages. Not necessarily all of them, not necessarily right away or in order, but oftentimes you'll see denial and anger before they get to the acceptance part. Usually they manifest that by objecting or resisting what you're telling them. So if they push back and say, well, what about this? Or he was fine last week, he mowed the lawn, what did you do to him? That shows that they're still in denial. They're not buying it. They just can't believe this is happening. It's too soon. They're not ready. They're not emotionally ready for end of life. They can't bear the thought of living without their loved one. And that's very normal to feel that way. So responding empathetically, acknowledging that you can see that this is not the result or the news they were hoping for. This must be very hard. I can see that this is upsetting, and you tell me more about what you're thinking or feeling right now, and how can we help before trying to give more information. So let's talk now about what is bereavement and what is grief. So bereavement is just the fact of having lost someone to death. Grief is the emotional reaction in response to bereavement. It involves emotional, cognitive, functional, and behavioral responses, and it can begin before the death actually occurs, and we call this anticipatory grief. And it may be prolonged afterwards. Anticipatory grief involves simultaneous and overlapping grief processes, and it addresses the losses that are anticipated or anticipate. So patients, they fear and they grieve the loss of their youth, their vitality, the opportunities that they would have had, their health, their functional abilities. They become more disabled. Their roles change. They become dependent instead of the providing one. Their identity is often tied up in their roles. So as they lose their roles, they have an identity crisis. Their sense of worth goes down, and ultimately, of course, they grieve the loss of their own life. Families, they grieve related to expectations that are changing, the physical and social dynamics of the family and the relationship and the function, as well as, of course, the prospect of losing a loved family member. So during this time, it's helpful to foster hope and try to help them set attainable goals, ask realistic hopes, and focus on being rather than doing. People want to fix things, they want to do something, but a lot of times just being present and supportive is helpful. There is the Hearth Hope Index, which is a tool that can be used in assessing and fostering hope. I put a slide at the end of this talk, and it'll also be available in the slides that were sent to Susan. So hopefully she can get those to you or make them available on the website. And then there are also psychotherapeutic interventions that can be done. So dignity therapy and meaning-centered psychotherapy, again, focusing on the value and dignity of one's life, kind of a life review, where it's showing where the meaning was, and just really helping focus on the deeper importance of that person in their life. Now, and I don't know if you can see the top of this slide because I've got the taskbar over top of it. I'm not sure how to get rid of that. But normal grief versus abnormal grief. You know, how do we know the difference? And then this is something they always put on the board, so you need to know this. And also, you know, abnormal grief is also called complicated or pathological or prolonged grief disorder. So almost everybody grieves after someone is lost, after the death of a loved one, but only 10% develop prolonged or pathologic grief disorder. The risk factors for that include sudden or traumatic loss, poor social supports, concurrent life stressors, multiple losses, and the presence of mood or anxiety disorders before the death occurred. Generally, normal grief is acute. It usually lasts about 0 to 3 months, but it's also a lifelong process that varies over time and is never fully completed. Anybody who has lost a loved one knows that every once in a while, you know, the grief kind of surfaces, sometimes quite unexpectedly. Someone has once termed it ambushed by grief. But people can move on with their life. They can still function. Prolonged grief disorder is generally, if it lasts more than 6 months, and there's even a scoring system or an evaluation tool. It's the PG-13R score, prolonged grief 13 revised, score of more than 25. And that's something that you can Google that. It'll come up and you can plug in the numbers and come up with a score. But it just looks at people's functioning and coping and things and some of their symptoms. So what are the symptoms? So normally people who grieve experience sadness, crying, depressed mood, yearning, emptiness, disbelief, fatigue, anorexia, insomnia, loss of interest, irritability, guilt, but they are able to experience both positive and negative emotions. And that's one of the big differences between normal versus abnormal grieving. Abnormal grieving, there's intense sadness and separation and distress, and it lasts a long time. Persistent low mood, feels like life is over, and negative emotions. And there's also some overlap and similarities with major depressive disorder, and we'll touch on that in a minute. Acceptance and integration is generally occurring with normal grieving. People find the new normal, meaningful ways of continuing the relationship with the deceased. For example, when my mother passed away a 1.5 years ago, my father put her picture on the dining room table, put a bouquet of flowers, had some meaningful things representing their life. And so there's not a day that goes by that he doesn't think about her, probably talk about her to everybody else, but yet he's able to function in life, in society. He's able to be active in his church and with friends. Whereas with prolonged or pathologic grief, people don't do this. They don't get to the point of finding a new normal. They're still kind of stuck in that, almost like they're stuck in the acute grief stage. Generally, normal grief doesn't involve maladaptive behaviors, but pathologic does. They're just so focused on the intense yearning, the sadness, they become either overly involved or excessively avoidant and estranged from others. Their function is persistently low and significantly impaired, versus normal grief, where it's an initial spectrum of emotional, cognitive, social, and behavioral disruptions, but later it normalizes. Normal grief does not adversely affect health. Unlike pathologic grief, there's increased risk of heart disease, hypertension, cancer, decreased immune function, and increased mortality, including suicide. All right, so how do we treat it? Well, it becomes chronic and unremitting if untreated, and it requires targeted, complicated grief treatment, or CGT, which is superior to psychotherapy alone. It includes cognitive behavioral techniques, interpersonal psychotherapy, and motivational interviewing, addressing personal goals, and helping them come to terms with the loss and finding a pathway to restoration. And if this has been going on for at least 3 months, then an antidepressant is also helpful, perhaps even a psychostimulant. Now, grief versus major depressive disorder, again, this typically shows up on the boards. So the difference is here, with grief, it's more of an emptiness and a loss versus a depressed mood or anhedonia. So positive emotions as well as negative emotions, and this is negative emotions. The dysphoria often occurs in waves triggered by thoughts and memories versus unrelenting dysphoria, feelings of worthlessness and hopelessness. The mood is reactive, and they can experience positive emotions where it's a pervasive and intractable low mood with major depressive disorder. Self-esteem is usually preserved, and guilty feelings are only related to relationship with a deceased versus low self-esteem and guilty feelings just in general. Thoughts of death are usually focused on concerning joining the deceased versus in MDD, it's aimed at ending one's own life. It's rooted in the feelings of hopelessness and worthlessness. Function is reduced initially in grief, and then it's variable, but usually normalizes versus MDD, where it's persistently impaired. Okay, so on that happy note, I wanted to end with this quote from Dr. Cicely Saunders, founder of the modern hospice movement in the UK. "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." So, hospice care is about living well for whatever time someone has, and then dying comfortably when that time comes. So in summary, I hope that you've been able to get a sense of the physiologic and prognostic signs that can be useful for recognizing and counseling regarding end of life, supporting families in addressing their common concerns, identifying and treating symptoms at end of life with comfort care, and identifying uncomplicated versus complicated grief versus major depressive disorder. Are there any questions?
Well done, Mike. Thanks so much. I actually had a question, and Pam put it in the chat box. It's the exact one that I had, and we've most of us have had circumstances in seeing elderly people who die who have spouses of decades, sometimes 50, 60, 70 years, and the spouse, there's a high correlation between 6-month mortality of the remaining spouse, regardless of any underlying health conditions. And Pam's question, and mine also, is that related to complicated grief, or is it something else?
I don't think so. I think that, as long if they're able to function, then they're not experiencing complicated grief. They are grieving, and it's, as mentioned, grief is a process, and it varies, and it can come and go even unexpectedly. But I think that it's natural for people to have a desire to go be with their loved one, because they've been with them for so long. And even though they love their family and don't really want to leave their family, they're also okay if they were to just die in their sleep. And that's, I think, one of the ways to ferret that out is, would they be okay? Is it more of a passive death wish? In other words, I'd be fine if I just fell asleep at night and didn't wake up and went to join my loved one, as opposed to wanting to do something active to hasten that process. That's where it becomes more abnormal and pathologic, where they're actually contemplating suicide. And actually, elderly white males have a higher rate of suicide. So it's certainly something to keep in mind as we have bereavement counseling and support. I think the longer and more complicated the relationship, the more likelihood it could be for complicated grieving, but it doesn't always have to be that way.
Yeah, my very, very non-scientific and somewhat more romantic view of that is that they have lost a vital organ, and we really can't survive without our vital organs intact. And there's obviously nothing scientific about it, but I think it sounds nice and it makes sense to me. And it sometimes makes sense to families when, Dad, yep, he's grieving, but he's functioning okay. but he dies 4 or 5 months later, and the families can sort of put their arms around the fact that a major part of his life is gone, and there's no replacing that or no restoring from that. Rob, I see your face popped up. You encounter this all the time.
Yeah, and I think that's an area that sometimes we can't explain, where sure that does happen. I've seen it happen, and then sometimes it doesn't happen. And then sometimes the family's surprised that mom or dad is still living, and they had been married for more than 50 years. And they would say, I'm surprised that mom or dad is still with us, because we thought that person would probably pass away soon after mom or dad passed away as well. But so, yeah, kind of depends, I guess, underlying comorbidities and what kind of stress that person is under, that type of thing as well. So sometimes that falls under the bucket, sometimes hard to explain per se.
And you've probably heard of the broken heart syndrome or
Right.
tachycerebral cardiomyopathy, where
Exactly. Yeah.
coronaries are normal, but the heart function is really low, often after bereavement.
Yeah. No, great talk. Appreciate it, Mike.
Thank you.
I wanted to just, something popped in my mind, Mike, shortly at the beginning when you were talking about the importance of goals of care conversations. And specifically regarding code status and things like that. I was with medical students yesterday morning. These are second-year students, and as I came in the room, they were chatting amongst themselves. One was particularly excited because she had participated in a code within the previous week, and that was just really exciting for her. And someone else said, well, I did too. And one of their other classmates that was not in the room, oh, he did too. I mean, they were talking with us in a very positive, really animated fashion about what it was like, and the kind of the anxiety and the thrill of that moment and the adrenaline rush and everything else. And as there was a pause there, I said, how many of those people survived? And they thought, it was quiet, well, none of them. None of them survived the code. And I said, well, that might be a good way to start our conversation today about why we're doing that, and the importance of having those conversations and discussions. And one student had commented, yeah, they pretty much only let the students participate in those that they don't think are going to survive. And someone else said, well, yeah, they're probably dead anyway. And, there was just, that was a nature conversation. So it really took a good conversation about, I think part of it is respect and dignity, but part of it is, why are we doing things to people that seem to be antithetical to proper medical care and probably their values as well. So I appreciate you coming off with that at the beginning. Other questions for Mike? The only other thing you had mentioned the PPS, and I just wanted to reemphasize the importance of that in helping determine hospice eligibility, but also with the caveat that the PPS was developed originally for cancer patients, and that was the patient population, and the hospice industry has sort of extrapolated that out and used the PPS to really look at functional capacity of patients that are under hospice care. And it's useful to be able to get a really good snapshot of what the patient's functional capacity is. However, someone, for example, with end stage, COPD or CHF, or especially like dementia, they may not change their PPSs, very frequently or very rapidly during the course of their hospice stay. And it does not mean that they're not hospice eligible because they're sticking at a PPS 40 or PPS 30. In cancer, there's a predictable decline through those 50, 40, 30, 12, and 2010. Not as predictable with other non-cancer diagnoses. So yes, you need to understand how to use it properly, but don't think that it's the be-all and end-all of prognostication for hospice eligibility. But your hospices will expect that that's part of the evaluation process.
Yeah, it's just a tool that you can use. One of many tools.
So, all right, thanks again, Mike.